A rate cutoff for 2025 Spring Congress is fast approaching. If you have yet to complete your registration for the conference at the Nerve Center for Optimizing Patient Care, do so today before rates increase. Our 8th annual event, chaired by Dr. Roger McIntyre, is being held May 8th through the 10th in person in Philadelphia and via simulcast online. Secure your spot today at nei.global/SP Congress 25RC. That's nei.global/SP Congress 25RC.
Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. This one on something that we don't always talk about enough. And with me today, full disclosure, is my clinical and research mentor, Dr. Anita Clayton, whom I trained with at the University of Virginia. How are you, Anita?
I'm good, except for it's snowing heavily outside.
I understand. You know, my son is there, and his classes were canceled, so he's on virtual.
I'm on virtual, too, covering the clinic, but it's done for now.
Great. Well, Anita is the chair of psychiatry at the University of Virginia and an expert on women's health, women's mental health, and in particular on the sexual side effects of some of our medications. So we're going to be talking about that and more with Anita. So Anita, let's get started. First of all, let's maybe define what are we talking about when we say sexual dysfunction? What does that mean?
Yeah, so we're generally talking in broad terms, but we need to break it down into smaller terms. So we need to think about hypoactive sexual desire. We need to think about arousal problems. So in men, erectile dysfunction; in women, lubrication and engorgement difficulties, and then orgasmic dysfunction. And we have seen that those things are all possible with medications. They can also occur spontaneously. So if people are distressed about that, then those are disorders. But what we have found is that related to a lot of the sexual disorders, there's a significant percentage of people who have depression, which might also then further impact on their sexual functioning.
Right. So it's actually very complicated to tease out, isn't it?
Yeah, it really can be. And you need to be looking at their past in terms of before they became depressed, for example, did they have problems in sexual functioning? And then did that change with the onset of the depressive symptoms? And then if you're coming into it sort of late asking about this, did it happen when they started on medications? Mm-hmm. And one of the key things I think to start with is say it's okay for us to talk about this because it's a common problem.
Right.
And also then ask them about preferences once you've made a diagnosis. You know, what side effects do they want to avoid? What we usually hear are, I don't want to gain weight, and I don't want sexual dysfunction. Mm-hmm. When they get some of the other side effects like sleep disturbance or cognitive dysfunction and things like that, those come up with our follow-ups and things like that. But we're not necessarily hearing that directly from patients when we first meet them and make a diagnosis.
Right. Well, how much of a problem is this? How common is sexual dysfunction in our patients taking meds?
Yeah, so we've looked at the rate of sexual dysfunction that appears to be related to major depressive episodes. Mm-hmm. And that's 50 to 70% of people.
Wow.
Remember, it's in the HAM-D. Mm-hmm. At least loss of libido is, although you can see other aspects of sexual dysfunction. Mm-hmm. Then if you start people on medications, we found that depending on the mechanism of action of medications, there are different rates of sexual dysfunction with those classes of drugs. And this really is a class effect. So that's why with SSRIs, you've just basically got unopposed serotonin enhancement, which then is going to feed back to things like dopamine and norepinephrine. They're all intertwined. And you will see between 70 and 80% of people on SSRIs will have a sexual dysfunction. Less with SNRIs because you're getting norepinephrine effects, which tend to be positive on sexual functioning in most cases. And that's about 45%. And then the atypical antidepressants, for example, have different mechanisms of action. And depending on those specific mechanisms, you can see very low rates of sexual dysfunction and potentially enhancement in sexual functioning, like bupropion or Gepirone ER. Not yet available, but we have the data on that. So other drugs like mirtazapine, vortioxetine, vilazodone, nifazodone, if you were ever taking that, agomelatine, people in other countries, those are all have low rates of sexual dysfunction as compared to placebo. Mm-hmm. When we're evaluating patients for sexual dysfunction in patients that have major depression, we also have to look at whether they had efficacy with the drug, because that might improve the depression-related sexual dysfunction. And if they didn't, then that may also be a factor or continue to be a factor. So really trying to sort that out is related to temporal sort of signposts, right? Before you became depressed, with depression, with your antidepressant, with a change in antidepressants. Yeah. And there are reasonably high rates of sexual dysfunction with the antipsychotics that increase prolactin.
Right. That's a killer, is the prolactin.
And it may be beneficial if you're getting an antipsychotic that has, for example, 5-HT1A agonist effects.
Okay. Well, this is great how you broke it. I love how you broke this down. And I guess the thing that you taught me, I'm not going to say how many years ago, Anita, was, first of all, don't be shy. Ask about it. Normalize it. It's a normal part of the human experience.
Right.
And creating a safe place, a permission structure, if you will, to talk about it is definitely step one. And, as we know, a lot of clinicians may not themselves be comfortable. And so they need to examine that. And I think need to kind of find a way to get comfortable talking about this. Otherwise, you're missing out on a big, big aspect of someone's life.
You're right. And we're not taught about it in medical school. And in very few residencies do we hear about it. And so people are reluctant to ask about it because they feel like they don't really know what to do or if there's anything to do. In fact, there was a study evaluating patients about sexual functioning and asking how they felt their provider might respond or why they would or wouldn't bring it up with their provider. And basically they said they were concerned that their provider would be like embarrassed or it was taboo, or there would not be anything that could be done about it and those kinds of things. Well, our patients should never feel like they can't bring something up because it might bother us. And we should get comfortable. In fact, when I was teaching large classes of medical students in their first year or so, I used to make them say masturbation out loud. Because people are afraid to ask about that. Like what? Right. People don't masturbate? Of course they do.
Yes.
And we need to be asking about that. Sometimes it's important to ask about porn use. And because that can contribute to sexual dysfunction with the escalating algorithms that we can see. The more porn you watch, the more it gets violent, the more it gets kinky, the more it gets other things that make regular sex, maybe with your partner, not enough.
Right.
And so we do need to ask about those things. And basically, one of the ways we introduce it is when patients are initially evaluated and diagnosed with a psychiatric condition, we give them the Changes in Sexual Functioning questionnaire, which I developed. So full disclosure there.
Yes.
But it gives them the opportunity to speak to what they're having right now before we have to talk about it. And so then we can go over it with them, and we can also use it to monitor outcomes with anything we do. If the patient doesn't bring it up, you need to bring it up as the physician or the provider.
Right.
Right? You can't just go, oh, well, they didn't mention it, so they must not have it.
Right. Well, it's funny you say that. I remember vividly, first of all, don't assume if someone doesn't have a partner that they're not sexually active. I remember vividly a gentleman with schizophrenia who talked very openly about his masturbatory life and how he was really upset the medicine was interfering with that. And if I assumed because he didn't have a partner that he didn't have a sex life, I would have missed out on an important part of his life.
And the thing is, if you have schizophrenia, you don't have that many pleasurable things in your life. And one of those might be masturbation.
Yeah, it might be.
You also don't have a lot of social interactions either that other people may have. And so again, that is a common thing that people do. I also am aware of women who masturbate before bedtime because it helps them sleep.
Yes, right.
So we don't want to interfere with it, whether it's with a partner or not.
Yeah, exactly.
And you probably do need to ask about partners' sexual functioning as well to your patient, because if their partner is older and having erectile dysfunction, that's going to contribute to their own sexual dysfunction.
Yeah, well said. Yeah. Well, the CSFQ, of course, I remember very well. Anita, you were starting to develop that when I was a resident. I remember seeing early versions of it, and it was really a big deal because before that, there was a scale called the ASEX, and your scale has a number of advantages over that. Mostly it was developed for medication trials to show change, things like that the ASEX isn't as good at. Am I right?
Well, the other thing has to do with how the threshold scores for sexual dysfunction were validated. So the ASEX has a composite score, but those scores on individual items were developed more from, does this sound like dysfunction at this score? And so it's really only validated for a dichotomous outcome. That is, do they have sexual dysfunction or don't they have sexual dysfunction? Right. The CSFQ can do that too, but it also is validated as a continuous measure. So you can look at change scores and they're very meaningful. So that's one of the things about it. One of the things I was thinking about recently was what was the most surprising thing for me in looking at sexual functioning. And the biggest thing was really that spontaneous reports are just minuscule compared to the actual level of sexual dysfunction. I first started thinking about this problem when I was a psychiatrist in the Navy at the National Naval Medical Center. Most of my patients were men, and fluoxetine had just become available. And so I was prescribing it because it was so much safer than tricyclics and better tolerated also, at least in terms of day-to-day things. But then people started talking about, to me, I'm having delayed orgasm. Some people that was good for, some people that wasn't so good for, or they weren't able to achieve an orgasm, or etc. And when I checked the package insert, it was 1.9% had spontaneously reported sexual dysfunction with fluoxetine. So I thought, you know what? We need a scale to look at this. And that's how ultimately I ended up developing one, because there really wasn't anything at that time at all.
Right.
But I think, then we found out that different classes of drugs have different rates of sexual dysfunction. Right. And I guess that was pretty surprising to me because, we really just had monoamine oxidase inhibitors and tricyclic antidepressants, and mostly we were using the latter. And people talked about all kinds of side effects because they were happening on a daily basis. But people really weren't talking about it. And then the rates with those are still almost 50%.
Right. Well, one of the other things I love about the CSFQ is it breaks down in the way that you described earlier, which is desire, arousal, orgasm. And that's very important because they're not always as connected as you might think, right? There can be disconnects there.
Yeah. And sometimes the drugs are acting more specifically or earlier in treatment, because with most of the medicines that we use, sexual dysfunction gets worse as we raise the dose.
Okay. So
when we're seeing people who have a little bit of problems going on and they may not think it's a big deal, but then when we raise the dose, it becomes a bigger and bigger deal. Then I think we really have to think about the opportunities we have to make life better for those patients. Because if you're feeling better from your depression, but you aren't able to have an orgasm or have the intimacy you want with your partner, then that's not a good quality of life.
Right. Absolutely. So I'm just thinking now, should we be taking that into account when choosing a medication? You mentioned preference for side effects. If somebody really says, look, I'm afraid of sexual dysfunction, should we choose out of the gate a medicine known to have lower rates?
Yes.
Okay,
I just mean it absolutely.
Yeah.
We all need to take into account what our patients do and don't want. And we have enough options to give them what they want, or at least try that. And we may as well try that to start with. Now, if their insurance company is saying you have to try them on an SSRI or whatever,
right,
I'd at least start them on an SNRI.
Okay. Yeah.
And the next step might be to move to one of those atypical antidepressants. Also, though, if they have some of those other adverse effects that might be benefited with some of those meds, like they're not sleeping, so mirtazapine might be a good option, or they have cognitive dysfunction too, then maybe vortioxetine would be a good option, etc. I think we have to step to those pretty quickly because people stop taking their meds if they're causing sexual dysfunction.
Yeah, and they won't tell us very often.
No, they usually don't, even though I check at every visit. So are you taking this? Are you taking this? Has anything else changed? But still, once they start to relapse, we might see that. And that's especially true, I think, for patients with thought disorders, because they have trouble adhering to their medications anyway. And if you take away one of the few pleasures they have, I think they're unlikely to continue to take it.
Yeah. Now,
and what would you want? That's the other question, right?
Right.
If I say, I don't want to have sexual dysfunction, and you go, well, I have to give you this one first because that's the order in which we do things. That would be ridiculous.
Yeah, of course. Well, it was harder a few years ago when we sort of only had SSRIs as generics. There are some other generic options, as you mentioned. Vilazodone has gone generic, for instance. Bupropion is another option. Yeah. I'm curious, you started to talk a little bit about the underlying neurobiology and mechanisms. Maybe we could get into that a little more. It obviously differs depending on the medication, but what are some of the common mechanisms underlying the sexual dysfunction?
So one of them is aging. Okay, so not a mechanism of action, but it is a process. And men tend to start developing sexual dysfunction about 10 years before women do. And those numbers increase from 40 to 50. And with each decade, women tend to start having sexual dysfunction more so in the perimenopause and postmenopause because of genitourinary syndrome of menopause. Also, though, hormones are part of that picture, right? So testosterone levels are dropping in men and in women. That's true too, but estrogen and progesterone are dropping as well. And so we start to see real problems with arousal and lubrication and things like that. The other thing is that we often don't think about birth control pills as causing sexual dysfunction, but they can. And that's such a nightmare because you're taking it so you can have sex without the fear of getting pregnant.
That's right.
And yet, it can be a contributor, and sometimes it is the cause. I can't tell you how many young women patients that we blamed their SSRI, took them off it, put them on something else, and they were still having this sexual dysfunction. They wanted to go back on the SSRI because they felt better. And so we changed them from an oral contraceptive to another method. And they got better.
Wow.
In terms of their sexual functioning. So that's one thing, is hormones. And the other big thing are neurotransmitters. And I already mentioned serotonin. If it's driving you, it's an inhibitory neurotransmitter with regard to sex and things like that. It leads to a sort of a sense of satiety, even though you don't feel it. Your body is thinking that. And so no wonder you don't get to orgasm, right? And then it's also regulating norepinephrine and dopamine, and tends to decrease their excitatory effects on sexual functioning. And we don't know that much about new mechanisms of action in newer agents and how much they impact on sexual functioning. They haven't been well studied at all. But we do need to look at that.
Right. So clearly medications that increase serotonin are a problem. You mentioned medicines that increase prolactin is a big problem. Is increasing prolactin more of an issue for desire, arousal, or orgasm?
It looks to me, although the data are not absolutely clear, that it starts with arousal and then it goes to orgasm and then it goes to desire. So it doesn't just stop and cause arousal problems. It goes on and ends up affecting the whole cycle. This also, though, if you think about it, if you're not, let's say you're a woman and you're not getting aroused, it could be painful to have sex then, right? And that discourages people from having desire or having sex. If you can't orgasm, that's a pretty negative outcome. And so then people are like, well, why bother? And so you do tend to see this. In fact, Judy Dunn was the lead author on a study we did using the Changes in Sexual Functioning questionnaire, looking at, in men only at that time, looking at when starting them on a drug that was being studied that never was developed, placebo or paroxetine.
Right.
And we monitored them at very close intervals because we could administer the CSFQ over the phone. They could push the phone buttons for their responses. And what was found was that the effects start at the back end of the phases of the sexual response cycle. So you first get orgasmic problems, and that was about day 4. And then day 6 to 8, you saw arousal problems. And then day 14, you saw desire problems and problems with satisfaction, which is another thing that we look at on the CSFQ and is important.
Right. And this was with the paroxetine part of that?
Yes. Paroxetine versus placebo. And I can't even tell you about the other drug because it doesn't matter.
No, I remember that well. I remember when Judy was studying that drug. I first met Judy. I was an investigator in the first study she ever ran. It was with Spradlin, actually, which is a medicine that doesn't seem to cause much sexual dysfunction.
Right. Or waking.
Could I go back to the prolactin elevation? Is it cause problems for both men and women? I mean, of course, we think of women, but men too?
Yes, men too.
Yeah, because a lot of men are on risperidone, for instance. Exactly.
And also drugs like risperidone can contribute to priapism as well, especially if you have a rapid increase in the dose that appears to be significant. Slower increases maybe are not as problematic in that way. But if that happens to somebody, they're not going to take that drug anymore.
No. And priapism is, remind me, it's alpha 1 or alpha 2?
I've forgotten too. I think it's alpha 1.
I think it's alpha 1 antagonism because risperidone has high, and that also orthostatic hypotension, I think. Right. Oh, yeah, it has to be. You know why? Remember iloperidone. Iloperidone has a priapism warning, and the highest affinity for that receptor is alpha 1A. Okay. Got it. I'm glad we figured that out.
And trazodone.
Yes, trazodone absolutely has it in the label. And yet, isn't it interesting? We give trazodone out to men all the time.
And women. And at high doses, especially for sleep and things like that.
Yeah.
Again, I think it's a rapid increase. You need to be careful, not just saying, okay, I'm going to start you at 300 milligrams a night of trazodone.
Yeah.
That range of response is from 25 to 400.
Yeah.
So, and I have seen priapism a few times in my career, but it was never trazodone.
Yeah.
And it's usually a combination of two drugs.
Right. Yeah, it's a lot like serotonin syndrome. It's hard to cause it, but usually it's a combination.
Right.
Could I go back to birth control pills for a minute? Because that was a little surprising to me. What is the mechanism of that causing sexual dysfunction? Is it the estrogen, the progestin? Or
it's probably the estrogen, and you start to see lower testosterone. Okay. Because what happens is estrogen increases sex hormone binding globulin, which is the protein that carries around hormones and such, and testosterone binds to that.
Got it.
And if your testosterone is bound, you have less bioavailable or free testosterone, which is the active testosterone. And women we've treated women with testosterone at times, much lower doses than men. They tend not to stick with it as much as, but we're also not giving them the easy administration, like an injection or something like that. So it is a problem that way. And there are certain people who have more of these CAG repeats in their androgen receptor. And that contributes to a greater likelihood that you will develop sexual dysfunction with drugs that are acting to reduce testosterone.
Okay. And speaking of factors that might increase the risk, are there genetic factors involved here? Because not everybody develops sexual dysfunction. It's
true. And there have been some studies looking at genetics. One of them, Jeff Bishop did a couple of them that have been published, and they both involved genes that related to serotonin and serotonin receptors. And it, like one is the promoter region for the transporter, and the other one, I forget exactly what that is, but both of those then, when people had those genetic mutations, they were much more likely to develop sexual dysfunction. And he especially found, again, young women on birth control pills in those studies on SSRIs had a much higher rate of arousal dysfunction than other women who weren't on birth control pills, and women and men too.
Yeah. It's interesting you mentioned that. I'm just thinking here, for the clinicians listening, they need to get used to thinking about the different stages here you're talking about, because you've got to inquire about each one. You've got to talk about desire and arousal and orgasm, and not just say, how's your sex,
Right.
Or how's your sex drive, which is what we're sort of taught to speak about. So
yeah, and we need to ask, are they satisfied with it? And you need to ask, is there a change?
Okay, right.
Okay, did they used to have great sex and they were very happy with it? Then when they got depressed, they weren't interested, and they didn't function very well either. And then their drug made it even worse.
Yeah.
And that is really important to people, that we're asking about it, that we're saying it's okay to talk about it, and we can do something about it.
Right, exactly. So really being more sophisticated in how you ask about this and how you think about, and especially differentiating, the related to the underlying condition versus the medication versus, as you said, other factors involved, aging and so on. So let's shift gears a little bit and talk about what strategies can we use here? Obviously, one is understanding the differences in the different medications and their risk. But what other kinds of strategies should we use in dealing with sexual dysfunction?
So one of the things this is sort of more on the back end, but once somebody has sexual dysfunction and we think it is related to their medication, then I think it's important to ask them, would they rather switch to a different antidepressant, or would they rather we add something like an antidote or to counteract this effect to some degree? I will tell you generally, in people who've been tried on multiple meds and they're finally on one that works, they want you to add something because they don't want to give it up. Right. People who've been started on their first antidepressant, which often happens, they get an SSRI and they have sexual dysfunction, they're perfectly willing to change because they believe, well, I'll respond to this next one too.
Right.
And so those are the two main strategies.
Right.
Long ago, there was a study that looked at drug holidays, essentially.
Uh-huh.
So the idea was that on the weekend you wouldn't take your medicine, so you could have sex on the weekend.
I remember
the problem
that.
was, for fluoxetine, that didn't work.
Didn't work
at all.
Yeah.
And for the shorter acting antidepressants, we found that I didn't find it. It was found that people basically had minimal effect, or if they had an effect, they also might have had discontinuation symptoms.
That's what I was just going to say. With paroxetine and SNRIs, that's a big risk.
Yes. And so then I always worried that people would, if it was beneficial for them, they would then not take it on Tuesday because I want to have sex on Tuesday night.
Right.
And then soon they're not taking their antidepressant.
Right.
And so that is not a strategy that I would recommend.
Okay.
Because our antidepressants, with the exception of things like zuranolone or esketamine or something, you've got to take them on a daily basis.
Right.
And you're going to have the side effects on a daily basis.
Right. Okay, now you mentioned antidotes. Let's talk about that. What are some effective antidotes?
So the earliest one that we studied was bupropion. And that's because when we started people on bupropion, people started saying, hey, this really makes me horny.
Right.
And I'm like, well, what's going on? So then we got interested in dopamine and norepinephrine effects on sexual functioning. And it's all about this balance between inhibitory effects and excitatory effects. And there are other things too. So like people who drink every day, they're going to have problems with their sexual functioning. People who smoke cannabis every day are going to have problems with their sexual functioning, and things like that. And also people take stimulant type of products or drugs from the street and they get an immediate effect, but over time they tend to have much more dysfunction.
Okay, interesting. So what about people with ADHD on stimulant meds?
We don't see a lot of problems with them because they're not, it's not abuse per se. But we also have found that stimulants are not antidotes to antidepressant-associated sexual dysfunction. I was
going to ask that, yeah. Okay, interesting.
So that sort of goes together, right?
Yeah. Yeah. Okay, so bupropion was effective, yes?
Mm-hmm. Yes. So was buspirone.
Buspirone, yeah.
The study looking at that, though, by Landon and colleagues, had a bit of a problem with the way that their data was analyzed. But it did appear that people who were on 30 to 60 milligrams a day, which is in the therapeutic range, did have beneficial effects on sexual functioning. And we know now that 5-HT1A agonists do have that.
Yeah. And that's the mechanism vilazodone and vortioxetine might share, right, for counteracting sexual dysfunction.
Correct.
Interesting.
At least one of the effects. Yeah.
Yes, one of them.
I would say.
Other potential antidotes. I was going to ask about stimulants, so that's not necessarily effective.
No, you can also add a second antidepressant that has a low rate of sexual dysfunction.
Okay.
There are types of psychotherapy, like mindfulness-based psychotherapy has been found to be helpful for sexual dysfunctions, and it can help in medication-associated sexual dysfunctions also. So those are probably the best ones.
Okay, good to know. How about cyproheptadine or any other kinds of
Yeah, that was one of the first ones we tried, and it kind of made sense to do it. Yeah. The problem is that people would fall asleep before they could have sex.
Well, that's not good.
No, and also yohimbine was another one that was tried.
I remember that, yeah.
Yeah, and so those often didn't work out. So now people are looking more, maybe not in their studies that they're doing for the phase 2 and 3 for regulatory studies, essentially. But they may add in like the CSFQ or something and look and just see if there's a signal at all, or wait until they have their positive studies and then they can try to look at it. In, I think it was 2012 or 2013, the FDA had a regulatory forum about how to design trials that might benefit patients, in that we could understand whether or not a drug caused sexual dysfunction, especially as compared to another agent like an SSRI. So Ni Kin is the lead author on the paper that provided guidance for that. And what they said was basically, you can do a study in normal, healthy controls. So we have done several of those. In fact, those were the ones that probably led to this suggestion, because you're basically eliminating the depression as an adverse effect on sexual functioning, right? So they're healthy controls without sexual dysfunction, and then you add paroxetine, or you add or placebo, or either one, right? They're probably not getting a lot of effects like on mood, even because they're not depressed. But we did see the sexual dysfunction, like in the study where Judy Dunn is the first author that I mentioned before. Then they also looked at what kind of studies needed to be done in patients with depression, right? So those studies, what they wanted was your drug, placebo control, and a comparator known to cause sexual dysfunction.
Oh.
So that you could determine that it wasn't a failed study if your study drug didn't cause sexual dysfunction, because versus placebo, right? But because if the SSRI you were putting it up against caused sexual dysfunction and your drug didn't, that is very good news, right? And it's good news for prescribers and patients.
Right.
And then also looking at longer term effects, because there were some data that showed that about 5% of people develop tolerance to sexual side effects after about 6 months.
Oh, I wasn't aware of that.
But it's a very small percentage. That means 95% don't.
Yeah, don't. Yeah, not good. Can sexual dysfunction come on later? I mean, for instance, with SSRIs, we know over time you're down-regulating dopamine more and more, and this leads to sometimes people feeling blunted, that kind of thing. Can sexual dysfunction come later, or is it always early? Well,
it depends. I would say there are plenty of people where they don't have it when they start on the treatment, and when they may have had sexual dysfunction from the depression itself, but it got better, or they never had it at all. And it works for them in terms of efficacy for their psychiatric disorder. And so they continue on that. One of the issues is, do we stop people's antidepressants in particular after a certain period of time, right? So we might, but then they might get their depression back. So then we put them back on it. And so then it happened. We try that one more time. So now they've had 3 episodes of depression. We know they're going to have another one. And so we continue their treatment, and they're aging. They're getting put on other medicines and other changes in their life that could then make it show up.
Right.
Medical conditions are big factors.
Right.
Medical conditions that affect the vasculature are really going to make a difference. So diabetes it has a high rate of sexual dysfunction just with diabetes. If their blood pressure is up, so cardiovascular disease of any sort is further going to contribute to onset of sexual dysfunction. Neurological diseases contribute to that. Antihypertensives themselves, so not just the effects of the cardiovascular disease, but the treatments too. And we need to think about those things in our patients. Yeah. We are very, and I hope other people are feeling this way too. We are pushing primary care doctors to treat our patients with GLP-1 agonists,
right?
Because they have gained weight, maybe from our drug, maybe they already had gained weight, et cetera. But that is not helping them in multiple ways. They might have sleep apnea. Right. You know, almost 20% of people with depression have sleep apnea and vice versa. Migraine, same things. And both of those are associated with sexual dysfunction. Yeah. So we need to treat them, but we first need to identify them. And we need to think about those in the mix, just like birth control pills, right? You wouldn't necessarily think that was a factor, but no, all of those things can be. And so we need to think about comorbid medical conditions and concomitant medications for those as well.
And of course, you know, you're talking about these medical conditions. We know they're way more common in people with depression. There's a strong bilateral association with obesity, cardiovascular disease, diabetes, as you've said, and sleep apnea. So these are things people need to be aware of as well.
Absolutely. And we can also see in people who are obese, and this is particularly important for men, is lowering of testosterone levels and increasing of estrogen. Yeah. Because remember, testosterone converts to estrogen. And so if it's converting more rapidly and storing in fat, we know it gets stored in fat too, then it's not available.
Yeah. Related to that, I wanted to get back to something else you said earlier that people may not be clued into, and that's cannabis use, which I believe the mechanism here would be also decreasing testosterone. And Anita, as you know, it's become ubiquitous. You go around from state to state. It's legal in many states. I can't get over how many people are using this. So how does that affect this?
So you could use cannabis occasionally. Maybe, and it may enhance your sexual activity occasionally. But if you start to use it daily, so it's chronic daily cannabis use, that's a problem in all kinds of ways, but it definitely contributes to sexual dysfunction. And so in studies we're doing, now we're even letting people into some studies who pop positive for cannabis on the UDS. Yeah. And we people aren't necessarily telling you the truth. We can, get the quantitative effect on that. But a lot of people are using it daily. And cannabis is so much more potent than it was even just a few years ago, and certainly from my youth.
Yes.
Not that I smoked cannabis, but...
Yeah. We didn't inhale, Anita, I know.
And
but am I correct though? The mechanism is lowering testosterone.
There are several mechanisms, actually.
Okay.
Yeah, and people don't like to hear that, and they don't. Just like cannabis used daily like that, and in large amounts and potent drug, because I can smell it when I'm driving down the road with my windows up. How potent is that, right?
Yeah, very.
So they don't really believe it because they've crept up to that, and they don't want to hear it either. The other thing is that a lot of the cannabis users who use it like every day to go to sleep or whatever are middle-aged or older.
Right.
And they already have risks for sexual dysfunction.
Right.
So it's just adding to the fire.
Right. I think the other thing that our audience needs to be aware of that we don't talk about enough is cannabis. First of all, if you smoke it, you get hundreds of different cannabinoids. Who knows what's in the smoke? But all of these cannabinoids have significant pharmacokinetic interactions. They actually interfere with some of the psychotropic enzymes and so on. And I don't think we fully understand because most of our psychiatric medications are metabolized by cytochrome P450. So I think we've got to be aware of that.
We do. And it's just like anxiety, though, with cannabis use. A lot of people start using cannabis because they feel anxious and it calms them down. But the more they use it, the less likely that is to happen. And you start to see significant. And same thing with nausea. And then you start to see people who develop a significant problem with nausea. And then you see people who have panic attacks that never had them before. And we suggest they go a month without smoking and see what happens. And invariably, those things stop.
Yeah. Now, related to that, you mentioned alcohol before. And of course, occasional alcohol use can help anxiety and, of course, can help sexual
desire, probably.
Desire. Yeah. And loosen inhibition and so on. But as you said, like with cannabis, regular alcohol use is bad for sex.
Absolutely. No question.
So darn it all comes back to moderation, Anita. I hate that.
Yeah, I don't hate that at all. I kind of like moderation.
Okay. Well, all things in moderation, including moderation. And
there we go.
Let's now get into some real clinical relevant stuff here. So we talked a little bit about untangling what's cause and effect here, what's causing the problem. There was one other question, Anita. I want to be clear about the time course here. When does sexual dysfunction typically emerge with psychotropic meds? Is it always early? Can it come on later? What's the pattern?
So it's usually early, but people are depressed and they don't notice it.
Okay.
So then also it can appear to come on later as their mood improves and those other symptoms improve. And we've talked about the people as they age or they develop other problems, medical or other psychiatric problems, we can see more sexual dysfunction too.
Yeah. You also mentioned something else very important. As people get older, they get put on more and more different medicines. And I don't know that we always are looking as carefully as we should at med-med interactions, drug-drug interactions. It's a significant factor.
Absolutely. It is.
Okay. Now, are there medications or treatments that are being studied that are showing promise to minimize sexual dysfunction?
There are some being studied for primary sexual disorders.
Right.
And I think that's, like, for example, men take PDE5 inhibitors for antidepressant-associated sexual dysfunction. Not that we've studied it, but interestingly, in the studies testing sildenafil for erectile dysfunction in men, they included about 25% of the patients who were taking SSRIs.
I did not know that.
Yes.
That's fascinating.
They only tested 750 men.
Oh, my. That's amazing.
When we went to try to get flibanserin approved, 11,000 women were enrolled in those trials because they were worried about the safety, even though the mechanism of action, 5-HT1A agonists and 5-HT2 antagonists effects, those don't cause you any problems. They don't make you pass out or cause which is what they were worried about. And they forbade drug and women who were taking the drug. They had a REMS that said, you must agree not to drink any alcohol at all while you are taking this drug.
Oh, my goodness. That's a deal breaker for a lot of people.
It really kind of was. And there are people who probably signed that and said, forget you, I'm going to have a drink. But if you look at the package insert for PDE5 inhibitors, they say things like, don't take this if you've had more than 5 alcoholic beverages. So men can choose whether they drink and take a drug, but women can't. And so it took a really long time to get that drug approved. We do use it in antidepressant-associated sexual dysfunction, especially if it's hypoactive sexual desire.
And You just mentioned two other antidotes in a way that we didn't mention earlier, actually. So furbanserin makes perfect sense. And then the PDE5 drugs.
Yeah. And we do add those to women as well as men.
Yeah.
And men could take flubanserin as well.
Oh, okay, I didn't realize
there'd be no contraindication to that either. And it probably, there's no claim for this, but the data showed that there were improvements in other aspects of sexual functioning, like arousal and orgasmic function with that too.
Right. So not just ED.
Mm-hmm.
No, that's great. Now, you and I are certainly involved with the development of several new mechanism antidepressants. I think one of the things that's exciting is we're in the third wave of psychopharmacology. Back when I was a resident working with you, that was the exciting second wave when the SSRIs, SNRIs were just coming out. Mm-hmm. But we've now gone beyond monoamines, I like to say. And you mentioned, for instance, ketamine and esketamine. We've got the combination of bupropion and dextromethorphan. You and I are working with kappa opioid antagonists, orexin and antagonists, and there's a variety of others. It seems like these newer mechanisms that are more targeted, perhaps, don't seem to have as much liability for sexual dysfunction.
I can't tell yet because they're not studying it.
Oh.
Okay. So, they can allow you to believe that, but they don't have the data.
Yeah.
It was looked at with zuranolone in one of the studies, but it was the mountain study that failed. At 30 milligrams. But it didn't look like it was problematic, at least related to that.
Right. And of course, with the kappa opioid antagonist, there's a possibility it might actually help, at least with anhedonia and the arousal, the desire part, I would think.
Possibly. We just need to prove it.
We just don't know. Right. We don't know yet. Well, that's a good point. And I should mention dextromethorphan, part of its mechanism, it is a modest SRI. So I guess we can't say that it's entirely free of that.
But 40-oxetine also has a modest SRI effect. Mm-hmm. And that is not a problem for it because the other effects overcome it. Yeah,
the serotonin receptor binding.
Mm-hmm.
Well, but that's still good news, though, that we may have more options out there. Well, certainly, we know that none of our antidepressants are universally effective. Depression is not one thing, so we certainly need new mechanisms to address the different neurobiologies and so on. So that's it's exciting. It's going to keep you and I going in our careers for a little while longer, Anita.
A little while.
Yeah, hopefully. Okay, now, there's another issue we should talk about. How do we have the discussion with a patient maybe who's hesitant to start or continue their medication because of sexual side effects? Again, getting back to, we got to learn to have the discussion and talk about this.
Yeah, but we also do need to reassure them that we're tracking it. Okay, that's one of the things that really does help. So when we give the CSFQ at the beginning, they fill it out. It might take them a little while, 5 minutes to fill it out. But when we repeat it, they can fill it out a lot quicker, and they can come back and say, I noticed this, and this changed, and they know we're tracking it. We do the same thing for weight. If people are worried about weight gain, we are going to weigh them in our clinic, and we're going to say, well, as much as you think you've gained weight, you haven't. Like in a lot of trials, people will end those and say, I think I've gained weight, and their weight is exactly the same as the very beginning of the trial.
Interesting.
So that's one thing. And also, some drugs get a bad rap for causing weight gain when, in fact, it's their appetite has returned because they had a very low appetite and they lost weight as a result or as a symptom of their depression. And then when their appetite returned and their weight gained back, they gained some weight back, they were unhappy and blamed the drug. It's like, no, I think it's the fork going to your mouth.
Good point. Well, of course, you're saying something that gets back to what we started at the beginning. I think to be a good clinician is to be curious. And people just need to be curious. And as you've said, ask a lot of these questions. And you said something else, track, measure, monitor these things. So if somebody's interested in the CSFQ, Anita, is there somewhere they can go to find out more information? And how can they even get a copy of it?
Well, for clinical purposes, I can give a clinical release for people to use it in a specific clinic that they're in or what they're going to do. And people should write me then for that.
Okay, so they should get a hold of you. And is there a website or somewhere, or maybe one of your articles they could look at just to learn about the CSFQ?
Well, we had the validation studies a long time ago with the CSFQ, but probably the more appropriate study is the more recent publication that looks at the 14-item CSFQ, because we actually worked with patients and had focus groups and things like that, and some expert opinion involved in developing, I think it's 31. We never use this anymore, but I think it was like 31 or 33 questions. And when we analyzed all the data, only 14 made any difference. And so we ultimately just took those 14 and interestingly, they're in separate phases of the sexual response cycle and satisfaction. And so that is called the short form, or the CSFQ-14 or CSFQ-C, different things people call it. But the first author on that publication is Adrienne Sheldon Keller.
Adrienne Keller, your longtime collaborator. I remember Adrienne.
Yes.
Right. Great.
So you could look at that. There also are, there's a fair amount of reveal in that as well.
Yeah. Well, that's great.
But I'm happy for people to use it clinically. It's just that industry probably needs to pay for it.
That makes perfect sense. And that's great. Well, if nothing else, as I said, just to get a look at it, to look at the items, or to really think about the different phases we've talked about: desire, arousal, orgasm, and then satisfaction. I just think that's a helpful way of organizing it.
So, and thinking about it, desire actually has 5 items. They have 3 and 2 looking at frequency and intensity. Because you think about desire, that's what you care about. Then I think there's 3 in arousal and 3 in orgasm, although one of them isn't a common effect, and then 1 for satisfaction. I think that adds up to 14.
Okay. All right.
So it really turned out to break down by those phases and the important aspects of those phases.
That's fantastic. Well, as we're getting close to the end of the time, I just want to give you a chance to give us kind of a wrap up here. And one way to think about this is, how can clinicians better screen for and proactively address sexual side effects? And how can they use this to improve patient outcomes and especially adherence to medications?
Yeah, I think we need to think about it like we think about other chronic long-term adverse effects, right? So if you're thinking about sleep disturbance, too much, too little, if you're thinking about cognitive dysfunction, if you're thinking about weight gain, if you're thinking about emotional blunting, you need to be thinking also about sexual dysfunction, because those are the things that cause people not to adhere to treatment. Yeah. Or they think, well, I feel well, so I don't need it anymore. Yeah. But they're going to stop it because they've got this problematic effect. And I think if we've started out their initial treatment diagnosis and plan, talking about this, what is your experience, trying to put it in temporal context for that patient, then we have a place to go forward from. And we do need to monitor over time. It's sort of like, I see a lot of women in midlife health. We have a women's midlife health center, and a lot of those women are on hormonal, essentially therapy. And a lot of times they'll go on vacation and they'll forget it. And they'll come back and they'll go, oh my gosh, I'm getting depressed again. It's horrible. You've got to do something. Nothing has happened. There's no crisis. And then I go through their meds with them, and then, oh yeah, I forgot that. Okay, well, let's get you back on that before we panic. Yeah. And it's those kinds of things. And people get so familiar with you if you're direct. and they're happy to be direct back
Yes.
at you.
Yes.
And they're happy that you've asked them and they trust you.
Yes.
And there's nothing more valuable for a psychiatrist than trust.
You know, something else I learned at University of Virginia is the 3 topics that are taboo that people never ask about that we need to be fearless are sex, money, and religion. And you might have been the one who taught me that, Anita, to be honest.
Those are important, though.
Yes. And so as we wrap up here, I really want to thank you, Anita. It is always a pleasure talking with you. I always learn something, as I have for 30 years.
Well, thank you, because I really appreciate you wanting to get this topic out in front of people to help them so that they can take better care of their patients.
Yeah, totally agree. And I want to publicly thank you also for my career. Anita taught me how to do the Hamilton Depression Scale and the CGI and taught me to not be afraid of pharmaceutical companies. So you and Randy Canterbury were instrumental in me. And so I guess in a way you created this monster and led to me doing these podcasts indirectly. So thank you very much for that.
I've told you before, it's the greatest pleasure when your student surpasses the master.
Yeah, I agree. I'm in that phase of my career now too, Anita. I'm always trying to identify and mentor talent. We both are.
Mm-hmm.
So I really want to thank the audience as well. I really hope you found this to be valuable. I certainly did, and I think it was very clinically relevant. For more information about our podcast and all of our other educational offerings, please go to our website, which is neiglobal.com. And hopefully you'll listen to our other podcasts, come to one of our meetings, come up and say hi. And Anita, thanks again. I look forward to seeing you sometime soon.
Me too.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.